Hi everyone, thank you Manos and Manos for this great opportunity to talk about this new alternative to a big problem that we have. Marco just showed that there is a good solution that is established for anterior glenoid bone loss less than 15%. However, we have a big problem in subcritical glenoid bone loss ranging from 10 to 20%, where you want to avoid doing the Latarjet because of the risk of complications and the learning curve. So we have this new option. This was first described in 2017 by Philippe Collin and Alexander Laderman as an arthroscopic procedure where you transpose the long head of the biceps through the subscapularis tendon to the anterior glenoid neck. But in their technique, this was an inlay technique, where you fix the long head of the biceps to the anterior glenoid using an interference screw. Then in 2019, Oleg Milina and Bruno Toussaint, who's here, suggested a different way of transposing long head of the biceps, but mainly fixing it to the anterior glenoid rim using suture anchors and working as a labroplasty, which is very important in this type of patients who redislocate frequently and who have a severe insufficiency of the capsulolabral tissue anteriorly, where you most of the times may not be able to perform a Bankart repair. However, these techniques are very complex, and as you see, you have the first case series that was published using Philippe Collin's technique was just published in December with only 22 patients for glenoid bone loss of less than 20%, and they reported a redislocation rate of 13%, which is relatively high, but the authors justify this with the high learning curve of this procedure and also maybe fixing an inlay technique with the tunnel too medially. So this is why Caterina, Angelo, and I looked for easier way to perform this complex procedure, which may be really a good alternative for this type of patients, doing it all arthroscopic, using all suture anchors, and trying to perform it as an onlay technique to have the labroplasty effect as well. So as you can see in this slide, what the modification consisted of transposing the long head of biceps through the subscapularis tendon to the anterior glenoid rim, but using two all suture anchors, 1.8 anchors, so low profile, each of them doubly loaded with sutures, 2 millimeter sutures that pass through the subscapularis tendon split, and then these 8 limbs of sutures are passed through the long head of the biceps, and then you perform 2 double pulley knots. You cut the long head of the biceps, and when you pull on the 4 opposing limbs, the long head of biceps shuttles intra-articularly to its position in the anterior glenoid rim, working as also a mini labroplasty, not like Oleg Milanen's and Bruno Toussaint's, but having more an effect of a labroplasty than the technique described by Philippe Collin and Laderman. So here is the short steps of transposing the long head of the biceps. You've seen the first anchor, 4 sutures, second anchor, 4 sutures, all 8 suture limbs pass through the long head of the biceps, and then you tie the 2 double pulley knots, tenatomize long head of the biceps, you pull on the 4 opposing limbs, and then it's going to neatly shuttle through the subscapularis tendon split to the anterior glenoid rim as seen here. So in the end, you have 4 knots fixing this sort of small labroplasty that blocks the anterior dislocation from happening again. And we perform this procedure all arthroscopic, as I said, and as you can see at the end of the procedure, you have only 3 portals, the anterior, the lateral, and the posterior. There are several biomechanical studies that have been published showing how this works, particularly the inlay technique by Philippe Collin, and they've shown that for cadaveric models of anterior glenoid bone loss ranging from 10 to 20%, this procedure significantly decreases the anterior glenohumeral translation when compared with the Bankart repair, with the advantage of no loss of external rotation compared with normal shoulders. Another study, a biomechanical study, showed in cadaveric models with a 13% of anterior glenoid bone loss that this procedure is significantly stronger by 16.3% versus the Bankart repair and by 16.6% versus the conjoint tendon transfer. Another biomechanical study for cadaveric bone models of 20% or less anterior glenoid bone loss by Mario Lubão in Journal of Shoulder and Elbow Surgery showed that the pectoralis low to dislocation favored the long-headed biceps transposition versus the Bankart repair. And what this allows us is to have the same sling and hammock effect as a Latarjet. And as you see in the scheme that I'm showing that's moving in the slide, what we produce is that in the mid-range of abduction, the first degrees of abduction and external rotation, the long head of the biceps that's going through the subscapularis tendon has a muscular hammock effect by pushing the subscapularis down. And when you increase the degrees of abduction and external rotation, it works as a sling in front of the humeral head, blocking the anterior translation and avoiding the redislocation. And yet another biomechanical study published this March in arthroscopy showed that in cadaveric models of 20% of anterior glenoid bone loss, this procedure reduces also the anterior-inferior translation versus the Bankart repair, and again versus the Bankart repair with a transfer conjoint tendon without any loss of external rotation. So it's a very promising technique if you look at the biomechanical studies that we have available to date. Of course, we have a very short series. We started doing this procedure in 2018, and when we looked at our series by the end of 2021, we had 16 patients. We had 6 months of minimum follow-up, so a range of 6 to 38 months. We have now 4 patients who have more than 3 years, reaching 4 years of follow-up. We have 5 patients who have more than 2 years. We have 10 patients who have reached the minimum follow-up of 1 year. But in this revision, we had 13 males and 3 females. The mean age was 24 years. The mean number of dislocation episodes prior to the surgery was 10 episodes, and they practiced mostly recreational sports, which were either contact or collision. And 63% of our patients had a glenoid bone loss of 10% or more. The mean estimated glenoid bone loss was 8%. 93% of our patients had a non-track lesion. However, and as I think Felix mentioned, it's very important to test preoperatively, and 50% of these patients who were on track had actually an engaging Ilsak's lesion, as shown in patient 8, for example. And 38% had a slap tear, and this is actually a very good technique for this type of patients where you can treat both problems, the slap and the anterior instability, with just one gesture. And our patients significantly improved. In fact, they improved 6 times more the minimal clinical important difference in the WASI score and 8 times more than the minimal clinical important difference in the ROE score. And patients improved significantly in range of motion regarding forward flexion, abduction, and internal rotation, and they improved in external rotation and strength, but without statistical significance. And most of all, and I think this is what worries us the most, and this is why our series is short, is because we were really careful about this, is that we are worried about the biceps when we transpose it. Does it heal? Does it not heal? Well, all of our patients, without exceptions, had no biceps complaints and no long-headed biceps complications. And you see here is one of the patients at 3 years, who is now almost 4 years, no biceps complaints whatsoever. They may have a cosmetical difference if you look very closely, but they don't complain about it. It's really negligible. You don't even see it if you don't look for it. And we had no recurrences at this time with this technique, but minimum follow-up is short, as we know. Each patient underwent an MRI control, and each and every patient had their long-headed biceps healed to the anterior glenoid rim at mean follow-up of 9 months. And so what we have to discuss here is what is the interest of this technique, this new technique, or why does it come up? It's because we know we have a high recurrence rate for the Bankart repair when you have 10% or more glenoid bone loss, and we want to avoid the complications of Latarjet when you don't have such a huge bone loss. So the DAS compared with the Bankart has the advantage of being a dynamic procedure where you can reproduce Latarget's effect, the hammock and the sling effects. Apparently, according to the biomechanical studies and our short series, there is no loss of external rotation, which is an advantage versus both of these procedures, because in each of these procedures you have a loss of external rotation, as you know. Of course, it's higher with Bankart. It decreases compared with the Bankart, the anterior glenoid humeral translation, particularly in anterior glenoid bone loss ranging from 10 to 20%, where you have a very high recurrence rate of the Bankart repair alone, as high as 17%. It deals with the slap lesion, as I said, so compared with these two procedures, it's a major advantage when you find a slap. You treat it by this type of tenodesis. However, it does have a great disadvantage versus the Latarget, which is the return to play. Of course, you can put your players returning to play full force at 4 months or 3 months even, possibly with a Latarget. With this procedure, we wait 6 months. So if the athlete is not willing to wait so long, it's not a good procedure, as it is not the Bankart repair. This is why most of our patients were recreational athletes. Also, we use no hardware. These are all soft anchors, all suture anchors. We have no neurovascular complications with the procedure versus the Latarget, because we don't traction the conjoined tendon to transfer the coracoid. So we are nowhere near the axillary nerve when we do the split, because we don't have to do it so low. And we can do it only with 3 portals. As you know, arthroscopic Latarget, you need as much as 7 portals, and it's all arthroscopic. You need no extra instrumentation. If you see that after all, this patient, it was on track, but now intraoperatively it's engaging, I'm afraid a Bankart and an Ilsak's remplissage will fail. It has a 7% recurrence rate in these cases. I can do a DAS with all I have to do the Bankart and the Ilsak's remplissage, and this is for me a great advantage. Of course, this is a very small, short-term series, so beware. We have good outcomes, yes. No bicep complaints, no recurrence to date. It's short, the follow-up in some of the patients, but it's safe. I think we've shown with this series it's safe. The long head of biceps heals, so this can be a safe procedure for patients with 20% or less of anterior glenoid bone loss and or a slap lesion. So thank you. This is our team, and we thank you for your attention.